I'd like to start by thanking Dr. Neely. Unfortunately, he couldn't be here today. He actually had to go out to a conference dealing with this very topic in Toronto today. It's a 3-day conference dealing with this issue. Essentially, our successes in the field of pediatric urology and urinary reconstruction has led to a whole new challenge in managing these chronic conditions in the long term. We're having increasing numbers of patients with spina bifida who are becoming independent and functional members of society and need a high level of care in the large world of adult medicine. They're having a difficult time fending for themselves. That's the issues we hope to address today. The objectives of this talk is to review pediatric neurogenic bladder, most commonly due to myelomeningocele or spina bifida, review its current management from a urological perspective. Then I would like to discuss the multidisciplinary care that is ongoing at BC Children's Hospital Spinal Cord Clinic and the successes that it has achieved. I will then review the long-term management of patients post-urinary reconstruction and their major complications. And after I've made my case that some of the issues that can arise with these complex patients in adulthood that require attention, I'd like to introduce a concept of transition care, some of the models currently in use, and some of the unique challenges posed by spina bifida in BC. So this isn't spina bifida, this is my son. He's had some influence on the talk over the past 5 weeks. He's perfectly healthy, but for some reason just loves to cry. This is myelomeningocele. This is what we're talking about today. It's the most common cause of neurogenic bladder dysfunction in children. The exact cause of failure of the spinal canal to close is unknown, but we know it occurs around 25 weeks gestational age when the ectoderm fails to close the neural tube. There's some confusion on terminology in spina bifida occulta, meningocele, myelomeningocele, lipomeningocele. For the purpose of this discussion today, they're all considered congenital abnormalities of the development of the spinal canal and will be used interchangeably. Management of neurogenic bladder is a significant component of any pediatric urologist practice. Up to 25% of all patients seen in the pediatric urology clinic have some form of neurogenic bladder. The most common cause of neurogenic bladder is myelomeningocele. It occurs about 1 in 1,000 births and has been steady over the past 20 years. Prior to this, it was much more common, and there was a dramatic reduction secondary to the introduction of folate supplementation and imaging advances. Other diseases or syndromes that can be parallel to spina bifida include sacral agenesis, imperforate anus, cerebral palsy, and spinal cord injuries. They should be kept in the back of your mind through the talk, but for as much of the principles apply, but we won't discuss them in detail today. With myelomeningocele, greater than 90% of lesions occur below the lumbar level. However, unlike cord injuries, the location of the defect is not associated with the region of dysfunction. In other words, the neurologic lesion produced by myelomeningocele can be variable, depending on what neural elements are inverted in the sac. Bladder dysfunction with spina bifida patients can be broken down into 4 categories based on urodynamics at initial assessment. A patient's lower tract can be synergic with favorable function. It can be dysynergic with or without poor detrusor compliance, or it can be completely denervated, or it can be any combination of. Infants at risk for urinary tract deterioration as a result of poorly compliant or overactive bladders or outflow obstruction from DSD need to be identified so appropriate prophylactic measures can be taken to preserve their upper tracts. The neurogenic dysfunction in bladder patients with spinal lesions is always changing. It's a dynamic landscape. The majority of the patients with occult dysraphisms may appear normal as a neonate, however, demonstrate concerning lesions as they grow older. Here we see that the vast majority of patients with spina bifida occulta can have normal urodynamic patterns. However, if we follow them into their childhood, here greater than 5 years old, we see that they have a mixed functional abnormalities within their bladder. This is important as all patients must be followed, and at this time we have no way of predetermining which patients will develop functional outcomes. The primary goal for management of patients with myelomeningocele are the attainment of social continence, preservation of renal function, and avoidance of UTIs. Urinary continence may not seem critical as preservation of renal function or the preservation or prevention and management as UTIs, but we must recognize that we are dealing with developing children and maintenance of continence is associated with higher self-confidence, social acceptance, and is a paramount issue for school-aged children. It is a primary concern for the well-being of patients with myelomeningocele. In our world, myelomeningocele is thought of as bladder dysfunction. However, it's truly a multi-system disorder. About 85% of Arnold-Chiari malformations obstructing the fourth ventricle, causing hydrocephalus. They may present with cognitive delay, attention deficit disorder, bowel, bladder, motor, and sensory abnormalities. They can have scoliosis and require numerous orthopedic surgeries. They require full multidisciplinary care and sacrifice from the family and supports that see them through their care. Their overall care must be coordinated by the healthcare team in order to limit the burden of this disease that has on the patient and its caregivers. The socioeconomic concerns of this complex disease concerns that this disease has on all parties must be kept in mind. In 1969, multidisciplinary clinics were a new concept. It was initiated here at BC Children's Hospital at that time. It combined a group of interested healthcare professionals to assess these complicated patients. It allowed specialists time to individually review the patients in the morning, then discuss their findings and collaborate with their colleagues' findings in the afternoon. It is essentially a one-stop shopping for the patients and their families. Most residents and students have been to the spinal cord clinic and spent a morning or two there. For those of you who haven't, it's a family-centered clinic held Thursday mornings at BC Children's Hospital. They see about 12 families per clinic. And in contrary to a general adult practice, the specialist waits in their room for the patients according to the patient's schedule, and the patients go from room to room seeing their specialists. At the end, they have a lunch and they discuss the patients. In the urology room, all imaging is arranged in the morning before their assessment, unless it's urodynamics, which is coordinated around each visit. Sometimes video urodynamics occur in the afternoon, but it's very convenient for them regardless. They see about 250 patients per year, with most being myelomeningocele and lipomeningocele, and about 40 patients per year with other spinal cord diagnoses. It was previously at around 300 and has been decreasing. The decrease is interesting. It may be related to folate supplementation, although a little bit delayed. It may still be gaining acceptance in more remote parts of the province. As well, neonatal screening and perhaps selective termination of pregnancy may play a significant role. Much progress has been made in the management of myelomeningocele patients over the past 50 years. A study from the UK in 2010 paints a bleak picture for survival of spina bifida patients back in 1967. They looked at 117 infants born with open spina bifida in Cambridge, England from 1963 to 1971. This was a community-based study with no loss of follow-up. All patients were followed by their JPs. It was done in the period after shunts were introduced, where shunts had a significant impact on survival, increasing from 20 to 80% in the first year of life. So at the time, long-term follow-up was unknown. All patients who were born with open spina bifida had their spina bifida closed within 24 hours. We see that death rate was 10 times the British national average, with a 25-year survival probability of only 50%. Only 39% in this population were alive at the age of 40, 1/3 dying before the age of 5, and the rest in a steady rate thereafter. Most deaths were due to urinary sepsis, epilepsy, hydrocephalus, or pulmonary embolus. Now this is vastly improved. This is a graph based on a cohort of patients of 904 from Washington from 1957 to 2000. Half male, half female. Demonstrates that 80% of this population is now surviving to adulthood, as opposed to 54% prior to 1975. Progress in the management of myelomeningocele over the past 50 years has been substantial. Widespread use of ventriculoperitoneal shunting has been associated with increase of survival from childhood. There is widespread introduction of folate, prenatal detection of spinal cord lesions with possible selective termination, as well as possible downgrading the severity of disease. Improvements in imaging of GU in the central nervous system has led to better screening and monitoring of patients. Improved mobility through physical therapy, orthopedics, and advancements in mobility devices has increased significant dysmobility concerns in this population. Management of their bowels, as well as recognition of the importance of support staff to the patients and the socioeconomic burden that these patients carry, has demonstrated a significant improvement in their quality of life. From our perspective, pediatric urology developed significantly in the later half of the 20th century. Initially, urinary diversion was the mainstay of treatment for children with intractable incontinence or abnormal upper urinary tract secondary to neurogenic bladder. The advent of clean intermittent catheterization in the 1970s, popularized by Lapides, was the first major step to conservative management. This is still done routinely, with or without overnight drainage. The development of reconstructive urology in children through the use of augmentation, cystoplasty, and continent catheterizable channels altered the management of pediatric neurogenic bladder through the 80s and 90s. Then, with refinements in urodynamics and the progressions of medical management with anticholinergics and Botox and other more conservative measures, another shift in management of neurogenic bladder occurred. The natural outcome of early functional investigation has been aggressive medical management in children who are at risk for urinary tract deterioration based on specific hostile urodynamic patterns. Conservative management has been seen as having increased importance. This has resulted in a statistically significant decrease in upper urinary tract deterioration compared with those children followed expectantly in the past, and a dramatic reduction in the need for augmentation cystoplasty. Here we see the picture of an ambulatory 10-year-old male with myelomeningocele. You can see his grade 4 left-sided reflux. His urodynamics show a poorly compliant, unstable bladder, and he has urinary incontinence as depicted by an open bladder neck. His ultrasound demonstrates moderate hydronephrosis with good preservation of his renal parenchyma. Initially, he was started on ditropan 5 mg PO TID and underwent intravesical Botox injection with some improvement. Unfortunately, he ended up needing a Metcalfe diversion. However, conservative management delayed his reconstruction. In this time, he was able to go through puberty, and he developed mentally as well as physically while preserving his renal function. On the other hand, there are some patients like this with a completely incompetent bladder outlet, a trabeculated small bladder, an unstable bladder with poor compliance and concerning depressive pressure, and he was considered for augmentation cystoplasty with Metcalfe and possible outlet procedure as soon as he was developmentally ready. He had it done at a young age of 5 years old. Current surgical management for pediatric neurogenic bladder serves several functions. First is to increase bladder compliance, decrease pressure, as a means of preserving renal function. This is most commonly through the augmentation cystoplasty. Secondly, to improve quality of life by allowing an easier route for self-catheterization with a continent catheterizable channel. Thirdly, to decrease urinary incontinence with a bladder neck reconstruction, suspension, or closure. And lastly, to reduce fecal incontinence through either a cecostopy or a MACE procedure. The MACE is a Malone antegrade continent enema. Bowel incontinence occurs in about 70% of the patients with spinal bifida. And having a cecostomy is an ideal way to flush the bowel to achieve better bowel continence. The Malone antegrade continent enema is a small plastic catheter that can be inserted in the cecum and allow for a stable catheterized channels. It's been shown to reduce fecal incontinence and improve quality of life. Almost always a cecostomy can be performed at the time of urinary reconstruction. Up until this point, we've mainly discussed care of the pediatric population. This is complex in its own right due to the functional changes and to the bladder during development. However, once the bladder reaches a stable functional development from a neurological standpoint, the situation certainly does not become less complex. We discussed preservation of renal function, upper tract monitoring, continence, and UTIs as primary issues in the pediatric population. This holds true as well as the long-term complications from urinary tract reconstruction, stones, their increased need for independence and self-care. 25% of patients with myelomeningocele fail to seek regular urological care. Despite a continued concern for upper tract dysfunction, multi-drug resistant UTIs, stones, and malignancies once they graduate from their pediatric clinics. Furthermore, the child is now an adult, has a desire for independence and an increased self-awareness towards image, continence, and perceived quality of life and sexuality. This occurs at the same time that caregivers begin burning out and the support for the pediatric patient has changed. I'd like to shift gears a little bit to the urologic issues by reviewing some of the long-term complications of urinary tract reconstruction in children. Big operations can have big complications. The most common complications are listed here, and we'll go through them one at a time. Let's begin with stones. Several studies show that patients with continent diversion are at increased risk for stone formation in the range of 18 to 30%. When they present, it can be quite a significant clinical problem in the management of their stones in the augmented bladder. Often their presentation is insidious with recurrent UTIs, hematuria. It is picked up incidentally on imaging, as their bladders are not sensate. The management of the stones is a topic for discussion on its own. It can be done by various methods. Endoscopic, percutaneous, laparoscopic, and open are all reasonable approaches and have been reported in small series with no approach proven advantageous over the next. These theories are retrospective, demonstrate large selection bias. Roberts et al. In 2004 looked at 60 patients, a total of 103 procedures, and they showed that whether stone is fragmented and removed endoscopically or extracted from an open procedure, there is no significant difference in recurrence. They did not comment on OR time in the study or level of stone burden. In summary, it's very patient-specific. You need to consider whether they have catheterizable channels, suprapubic catheters, ileal conduit, or an open urethra. Generally, the preference at BC Children's is to proceed with open lithotomy. Here is an example of a patient post-open cystolithopaxy who had fantastic results. You can see the significant stone burden in their augmented bladder on the preoperative imaging on the right. Post-operatively, you can see that they're stone-free. Unfortunately, 32 months later, he had a significant recurrence. This brings me to the point that we must not only deal acutely with their stones, but we must work to reduce their stone formation. Due to stone formation, we can ensure no mucus buildup with appropriate flushing, adequate hydration, assess for possible foreign bodies, regions of stasis, treat infections, and address metabolic issues caused by their diversion, such as enteric hyperoxaluria or metabolic acidosis. I want to highlight the importance of issues of dealing with their metabolic complications just by looking at a few more patients with stones. This young man with a low level of myelomeningocele had a horseshoe kidney. He underwent a series of procedures as a child to achieve continence. Ultimately, he ended up having a bladder neck closure, augmentation cystoplasty, and a Mitrofanoff diversion. He was followed regularly in the spinal cord clinic, but despite his follow-up, he presented one evening in septic shock. He was initially investigated for a ruptured augment, but his CT cystogram revealed a stone impact in his right distal UPJ in his horseshoe kidney. Now, because he was so kyphoscoliotic, and because the pelvic location of the horseshoe kidney, percutaneous access was not a possibility in this patient. His bladder neck was closed, so an approach through the urethra or endoscopic approach was not available. So he required open of his augment and insertion of insertion of a double J ureteral stent through the augment into his kidney. He ended up doing very well. He was fortunate, as opposed to this patient with spina bifida who previously underwent augmentation cystoplasty. Unfortunately, she was lost to follow-up as an adult. She represented at one point in time to a community hospital with sepsis secondary to XGP. She was transferred to VGH. She underwent emergent and expedient care by the urology service here with open nephrectomy. Unfortunately, she died post-nephrectomy with respiratory and nutritional complications. Moving from one nightmare to the next, augment rupture. Augment perforation is a considerable risk in this group, occurring 3 to 9% of the patients post-augment. Indianapolis released a series on 500 patients post-augmentation with 25 years follow-up, and they identified a 0.6% chance per year risk of perforation. A third were initially within the first 2 years, a third from 2 to 6 years, and a third in the long term greater than 6 years. Vancouver has seen 3 perforations here.
You can make it 4. We have one in ICU.
Oh no. Okay. Okay? Is he okay? Sorry. Sorry, I didn't update my slides at 4 in the morning. Vancouver's at 4. What was the cost? We don't know. Okay. Spontaneous, maybe? Okay, so we've had 1 that's been traumatic and possibly 3 that are spontaneous here. This teenage babe post-augmentation bought himself a laparotomy after getting drunk on his motorcycle. He wiped out and hit his lower abdomen on the gas tank. He had a full augment this time and he ruptured. It was a fairly relatively straightforward clinical presentation, required urgent closure, and he did very well. However, augmentation perforations can be spontaneous, and the etiology is often unknown. It could be due to non-compliance, traumatic cath, infection, or ischemia. Risk of perforations has been shown to be increased with sigmoid colon, Use, likely result of the increased peristaltic contractions when due tubularization was not done. Bladder neck reconstruction is also a risk, as the fixed outlet obstruction may contribute to high intravesical pressures. However, urodynamic data is not available to confirm this theory. Use of a catheterizable channel has been shown to be protective against this. Here's an example of a presentation that was not straightforward. This teenage boy presented with abdominal distension, low-grade fever, and headaches 1 year post bladder augment. He had a ventriculoperitoneal shunt at the time. A CT cystogram was done and it was negative for leak, so neurosurgery was consulted. They thought that it may be a VP shunt malformation. However, when they aspirated the fluid for culture, it grew the same Klebsiella that was growing in his urine. So they did a laparotomy, and they couldn't find the leak despite use of methylene blue. In summary, augment rupture can be quite clear in some cases, but not always. A high index of suspicion is needed. Beware of a grumbling UTI in a patient with post-augmentation. CT cystogram is the best initial test, but not 100%, and often repeat imaging is required. They may be managed with urinary diversion and drainage if possible. However, if the patient is unstable, management requires immediate laparotomy. Here's another patient post-augmentation with fluid in the abdomen. However, this was not urine and was not a rupture. This patient presented 1 year after augment, abdominal ascension, and headaches. And with this CT picture, he was suspected to have an augment rupture. But this turned out to be an obstruction of the shunt and was called CSF-OMA. You can see a loculation of the CSF fluid secondary to adhesions. The CT looks very similar to the last patient, and it's important for urologists to have this in our mind when we're seeing patients with fluid in the abdomen. It's not always a rupture. The purpose of the shunt is to drain CSF into the abdomen to relieve their hydrocephalus. Occasionally they can malfunction or they can get infected. They have a 6 to 11% incidence post-augment, whether it is due to infection or instruction. In Vancouver, there has been 1 infection and 2 patients have developed obstruction. Haven't had any of those past 24 hours, Dr. Upshaw.
No, not. The patient that you showed that the exploratory didn't find any rupture is a patient that is not in ICU.
Oh, really?
The same patient. So it happened again.
What was the time delay?
About 10 months.
Okay.
They're usually teenagers. There's probably a problem with compliance. They're not catheterizing frequently enough.
Management of the shunt complications from our perspective is pretty easy. We call neurosurgery. We can help with their aspiration of the fluid and diagnosis. Then neurosurgery will go on to either exteriorize the shunt, reposition it, or create a new third ventriculostomy. I'd like to deal with the issue of secondary augmentation. The need for additional secondary augment is the second most common reason for surgery following augment in the Indianapolis 500 series. More common than bladder perforation, and much more common than bowel obstruction or malignancies. That being said, the majority still don't require additional surgery. The overall incidence is 9% in the series. Vancouver has had 3 patients requiring repeat augment. The main reasons for the second augment is continued incontinence, upper tract deterioration, secondary to a refractory, poorly compliant bladder with high pressure. Major risk factors are use of gastric or colonic mucosa for the flap. The 3 in Vancouver were ileal and cecal donor sites. Here we have a patient post-ileal cystoplasty with continued overactive bladder and poor compliance. His CT cystogram shows a trabeculated, contracted bladder with the augment maximally distended. His urine dynamics just demonstrate a very hostile bladder with poor compliance, uninhibited contracture, and sphincter dyssynergia. Moving on to issues of stomal stenosis, strictures, leakage, and fistulas. Vancouver has published their own series on stomal stenosis, post-urinary continent urinary diversion. Over 6 years, they had 67 patients, the majority female, who had continent urinary diversion. Median age of the cohort was 12 years with a median follow-up of 28 months. The vast majority of the channels were Mitrofanoff appendecovesicostomy. 13 of the patients required use of their ileum, whether it was spiraled in a Casal fashion or detubularized in a Yang-Monti fashion. The majority of their complications have been issues with stenosis, stricture, fistula, and incontinence post-creation of the channel. Leakage was the most common, and 2 patients in the cohort required a revision, and 1 patient had complete removal of the channel. Stenosis and stricture rates each occurred in 6% of the time, requiring 2 endoscopic repair and 3 revisions, one of which was conversion of the Metcalfe to a Casal. Stenosis is generally managed by dilation and an indwelling catheter for about 2 to 3 weeks. Then they proceed to applying steroid ointment and CIC for about 6 weeks. All these cases were able to be managed conservatively. Prolapse is more common in this population, but occurred in 2 patients, each of whom required a minor open revision. No difference between type of channel used and continence rate was seen. This may have been due to the small numbers of the other channels used. Follow-up was 28 months. It may underestimate the eventual long-term complication rate, as we know from the original Metcalfe series that channeling issues can develop over long-term and may be related to body habitus and body changes as they develop. Sick Kids published their series on 189 patients with a mean follow-up of 5.8 years. 81% of the cases were Metcalfe, 17 were Monty tubes. 39% of their patients required a surgical revision. There is no difference between the use of appendix or detubularized small bowel in complication rate as defined by the need for reoperation. As well, there is no difference in the use of right lower quadrant site versus the umbilicus. We're almost there. You'll notice I don't even have on this list vitamin B12 deficiency, growth retardation, hyperammonemia, rickets, and recurrent UTIs. I tried to stick to more of the surgical list. I want to focus on malignancy as they become adults, then sexuality, then fertility. Malignancy occurs 1 to 4% of the time post-augment in the pediatric population at a rate of 0.4% per year after 10 years. It is often late occurrence. It can be high-grade adenocarcinoma when it does. Surveillance with annual cystoscopy every 10 years is often quoted and recommended based on the incidence. However, the few studies that looked into the benefit of surveillance found that most often they presented with symptoms between surveillance episodes, and surveillance didn't prove any benefit. One recommendation is to do a regular cystoscopy and then proper evaluation with symptoms, but this is debated and based on low-level evidence. Sexuality can be a very large topic in this cohort. However, it is very difficult to study, as studies are largely qualitative. A few points are known. Number one, it must be discussed with the patients and the family. Whether they voice them or not, they undoubtedly have questions. As well, the probability of them developing interest in relationships, as well as the probability of them having intercourse, is likely. However, it is dependent on their level of function, which is related to the level of lesion and hydrocephalus. Developmental delay, immobility, and continence all play a major role in their sexuality. With regards to fertility, male considerations are erectile dysfunction, antegrade ejaculation, and must be considered based on their level of neurological deficit, as well as whether or not they've had a procedure to their bladder neck. For females, they need counseling regarding the effect of UTI in pregnancy, as well as considerations to any dysmorphic features such as scoliosis that may present, that may affect other systems such as respiratory function during pregnancy. It has been estimated that with proper folate supplementation and no identified familial history, a patient with spina bifida has a 4 to 7% chance of having offspring with spina bifida. The patients must be counseled on this. Stomas and augments are of concern during pregnancy. At Women's Hospital, 3 patients with prior augment have had a cesarean section. Allegedly, in one, a gynecologist tore through the augment on his way to the uterus, and this needed to be reconstructed. However, just over a month ago, Dr. McNeely and Paul Gustafson got called for a cesarean section. Took them a couple hours, but they managed to help the gynecologist navigate around the augment. The baby was delivered successfully in a pre-planned cesarean section date, and the blood supply to the augment was maintained. It can be recommended that urologist presence at the time of cesarean section during augment and anticipation of complications with the augment should be made during pregnancy. As well, this should be made to consideration for any surgery in the pelvis later on down the road, such as hysterectomy or colectomy. So disasters can happen post long-term reconstruction of the urinary tract, and this needs to be followed. And even reconstruction aside, myelomeningocele patients need long-term follow-up. These patients are out there. On average, 10 patients per year graduate from the spinal cord clinic. These patients are moving from a very structured, patient and family-centered program and entering the independent world of adult healthcare, where they need to navigate the system on their own. Making the jump smoothly is important. This is what I want to talk about today. It's defined as transition care. The purpose of a specified youth transition process is to provide uninterrupted, coordinated, developmentally appropriate, and psychologically sound health care to young adults as they age out of pediatric care and into the care of an adult health care provider. Transition is an issue across all health disciplines. Diabetes is the most common chronic illness requiring appropriate transition. However, it's present in all conditions. Diabetes, renal failure, cystic fibrosis are the most studied areas in the field. The art of transition deals with allowing the patient with the chronic disease to learn and master skills needed for successful adult life. They must become appropriate decision makers, learn self-care, hygiene, improve socializing skills, have relationships as well as obtain work skills and find meaningful pastimes. You can see that each transition protocol should be illness, symptom, and age specific. There are several models for transition. For example, the System Navigator model. Each patient gets a coordinator who helps the patient with scheduling of appointments, establish relationships with new providers to prevent a feeling of being overwhelmed by the system. This has been used successfully by the Pediatric Nephrology program here in BC. Self-management models are focused on helping young patients develop necessary skills and knowledge to advocate for themselves, maintaining health-promoting behaviors, and utilizing healthcare services. This type of model focuses on development of alliance among the youth, the families, and healthcare providers early in the process, followed by a gradual shift as the adolescents develop more responsibilities. This model is currently what's being applied with cystic fibrosis. Individual transition models are designed to meet the unique physical and cognitive abilities for young adults and their families. With this model, the onus is on successful transition provided by the pediatric care providers. The young adults are introduced to the program in early adolescence and introduced to new tasks or skills that must be mastered before moving on to the next stage of transition. This would be what we'd see for very severe, diverse, multi-system chronic illness, potentially such as that seen in the myelomeningocele patients. The type of model required has been studied in spina bifida patients. A qualitative multi-site study studied the adaptation in young adults with spina bifida, and it was published in 2011. And patients range from 18 to 25 years. They discovered that the largest barriers for patients to overcome was their struggle for independence, that they had limited social interactions, and they felt a need to build inner strength. You can see this is in stark contrast to what we focus on day to day, and we must recognize that addressing these issues may be what is missing in their transition care. We focus on urological issues of incontinence, sepsis, stones, renal failure, and sexuality. Other physical challenges are shunt and shunt complications, cognitive delay, pulmonary problems, limited mobility, and skin breakdown. However, we must consider the neuropsychological challenges that accompany spina bifida. They have lower levels of autonomy, they're overprotective and often burnt-out caregivers, social dependence, and social anxieties with poor interaction skills. These issues must be addressed in order to address their more physical concerns. So transition spina bifida is complex, and likely even in the adult world, multidisciplinary care may be required. However, we must also consider our resources. There are 2 successful adult multidisciplinary clinics in Canada that were essentially graduated myelomeningocele patients. These are both in Edmonton and Halifax. Edmonton is in a unique situation where the pediatric hospital is within the adult hospital, and the pediatric surgeons have an easier time applying for privileges for the adult ORs. Getting OR time, however, is another issue. It is one of the few centers in North America where there is an adult multidisciplinary clinic, spina bifida clinic. It is held at the Adult Rehabilitation Facility. It's the Glenrose, which is our equivalent of the GF Strong. It consists of regular visits depending on stability and complexity of the patients, anywhere from a once monthly to once yearly visit. It consists of pediatric urologists, a neurosurgeon social worker, and spearheaded by a physiatrist. You can see this is in contrast to Indiana, which is potentially one of the busiest centers for urinary reconstruction and neurogenic bladder in the States. Here, once they reach adulthood, they're almost unanimously on Medicare due to the high costs of their insurance, and are followed by county hospitals and by GPs, who are often very busy and completely overwhelmed by the complexity and level of care of these patients. They get around this by having a very strong focus on transition in the adolescent periods, and gradually increasing their independence. In BC, patients given appropriate transition care goals by the spinal cord clinic, which are disease and patient specific. Ideally, these goals are met upon graduation from the clinic. Currently in Vancouver, we have lots of tertiary care with the GF Strong, the Eye Care Center, Bladder Care Center. They're still segregated, but communications are available. Physiatry is gaining an increasing role at the GF Strong. However, there's still potential to improve with less loss follow-up, potentially through adult multidisciplinary clinics with improved transition care strategies. And undoubtedly, there will be the patient who turns 18 who will want to go back to their community and not want to deal with the tertiary, quaternary level care, and this will become the community urologist's responsibility. In conclusion, sorry, we're almost done. My wife's excited for me to do that. In conclusion, we have made huge gains in the management of myelomeningocele patients. However, with complex reconstructions, we have opened a can of worms in dealing with these patients as adults, as not only do we have to deal with the complexity of their disease, complications from their previous management, as well as balance of their chronic disease with new illnesses they can acquire, but we have to achieve this balance with their unique psychosocial needs. Effective and accessible care in the adult world is essential, and there are many barriers to providing effective care, as well as effective transition to this care. Questions?